Welcome to tonight's ASCP Town Hall event. I'm Dr. Blair Holliday, the CEO of ASCP. Tonight marks our 12th Town Hall event. We started these live Town Hall meetings back in April as a way for us to not only keep you informed, but also to provide important changes within our laboratory and pathology community, but mainly as a way for us to still stay connected during these turbulent pandemic times. Information about the pandemic, as you know, changes rapidly as the number of those diagnosed in our country continues to rise, as does the death toll from this virus. Daily, we are inundated with information around testing, treatments, the long haul, the long-term effects of this disease. And honestly, it's nothing short of a challenge to process all of what it means and understand where we need to go. So tonight, we're going to look at where we stand in this fight against COVID-19 in the United States and what steps we need to take moving forward, both the near future, as well as to get our country back into a place of normalcy, and what we need to do to prevent a future pandemic. Now, in the past 6 months, the United States has been in an uphill battle against the fight of COVID-19. The number of Americans infected continues to rise. Recently, we're topping 5 million infected, and the death toll is approaching 180,000. And since the first case of COVID-19 was diagnosed in the United States in January, followed soon after by the World Health Organization declaring it a global health emergency, COVID-19 has upended just about every aspect of life as you know it. The pandemic has taken its toll on the economy. It's frayed the fabric of our social networks, our personal lives. It's stressed and strained our healthcare system to epic proportions. Now we know there are multiple platforms that we use to test for COVID-19, and the research has given us, fluctuating and understanding what we need to do to look at what this disease looks like in the short and long term. But although the system has been a little slow to implement the needed testing at the rates required by our citizens, which increases the vulnerability of our populations around the country, there's been significant progress. And now therapies are being developed, and hopefully, as you know, vaccines are getting closer. But with 6 months of this pandemic behind us, we can't help but take stock of where we are in the fight against COVID-19. And while some states have progressed to a place where they can safely reopen some businesses or even schools, other states are still mired in spiking numbers of cases. And now, with summer quickly coming to a close, and as we transition to a new season, we have to look ahead to where we're going to go from here as this virus rages on. What we have to do and the work we have to do to tirelessly slow the spread of this disease. Few truly understand the toll that this pandemic has taken on healthcare. The laboratory is unique in that we have been on the front line since the beginning, but joining us tonight for our special discussion about the state of COVID-19 in the United States are three nationally renowned experts, individuals who have been central to the ongoing sharing of information and the development of SARS-CoV-2 in the laboratory and our nation's response. So please allow me to introduce you to, first of all, Dr. Gary Prokop. Dr. Prokop serves as not only the chair of the ASCP Commission for Science, Technology, and Public Policy. He is employed as the Belinda Lieberman and James Lieberman Endowed Chair in Clinical Microbiology, the Vice Chair of Education of Pathology Lab Medicine Institute, and Professor of Pathology at Cleveland Clinic, Lerner College of Medicine at Cleveland Clinic. Dr. Prokop, please say hello.
Hello, thanks for having me.
Also joining us tonight is Dr. Karen Call, who is not only a physician, but also a scientist. She's the chair of the Department of Pathology and Laboratory Medicine at Duckworth Family Chair at North Shore University Healthcare System and clinical professor of pathology at the University of Chicago Pritzker School of Medicine. Dr. Call, please join us in saying hello.
Thank you, Blair. Happy to be here this evening.
And last but certainly not least is one of our own, but she serves as the Associate Director of Laboratory Preparedness. Jasmine Chetram is has a master's in public health, but is also a a medical laboratory scientist and certified by the ASCP. And she's risen to the ranks of Chief Informatics and Data Science Branch at the CDC Division of Laboratory Systems. And we are very proud to have her tonight as well. Jasmine, say hello.
Hello, everyone, and thank you for having me. And I do want to apologize in advance for any delays in my audio or video because we are having severe thunderstorms in Atlanta tonight.
Very good. Thank you for the update, Jasmine. And we're looking forward to the conversation. Now, before we do so, remember, I'd like to remind all the attendees and viewers that you can submit your questions through that Q&A function at the bottom of your screen. And now let's show the disclosure language for compliance with, there you go. Okay. So let's get straight to the questions, shall we? And I'd like to start off tonight by getting a sense of, well, the experience the laboratories have had over the past 6 months. Dr. Call, let's start with you. From your experience, how do you think our laboratories have handled COVID-19 response? What have we done better and what did we do wrong?
Well, from the laboratory perspective, I'm actually quite proud of the way laboratories have responded. You know, we found ourselves in a situation where it really took a grassroots effort among the labs to prepare ourselves for this. You know, we'll probably touch on this later, but we haven't had federal guidelines. We've had significant shortages. There weren't existing assays when this started boiling up in January. And so individual labs started working to do what they can to be prepared. And many of them have done immense numbers of tests, as you well know. But there hasn't been, you know, a national standard. There hasn't been the availability of reagents. So it's been a real uphill battle. Despite that, hospital laboratories are doing a significant amount of the testing and are really serving their patients on the front lines of this disease. And I think have had an enormous impact on how individual institutions have been able to respond you know, to this virus, appropriate use of PPE, hospitalization, cohorting, and so forth. But it's definitely been a struggle, and it continues to be such.
Let me ask Dr. Prokop the same question, but slightly different. Gary, tell us, what one thing would you have changed that you think would have had the most impact and why as it relates to this pandemic?
Well, you know, preparedness, I think, is the one thing I would change, right? And so Dr. Call touched on some of these. If we had opportunities ahead of time to build these assays, we wouldn't have had to scramble for these assays. If there was greater preparedness with regards to stockpiles and of all the materials that we need, if there was, you know, foresight with regards to earlier deployment of Defense Production Act, for example. So I think it's, you know, preparedness is a large umbrella, but that's the one thing I would change. And I think we would want to look at that, you know, in the postmortem that occurs after COVID-19, that's what we'll want to do. And I think what's really important is, you know, in the hospital, when we do a morbidity mortality conference, it's usually because something went wrong. But we don't do it to ascribe blame. We do it to fix processes. And that's exactly what we'll want to do here.
So let's stick to that. So obviously your day-to-day operations have massively been affected by this pandemic. You know, your triaging of testing as well, et cetera, et cetera. But tell me a little bit more about some of the positive changes that you made in your lab or in your approach to daily practice that you think should be sustained or improved, that can help improve patient outcomes even beyond COVID. Share some of that with us.
You know, I think probably one of the biggest things is how the laboratory has become front and center in this. And we've really always been involved in hospital team operations around COVID. And, you know, I think, you know, Karen will likely agree with me. There's just way too many times that decisions are made in hospitals and the laboratory becomes an afterthought. You know, I think we've really demonstrated how important laboratory medicine is. And I think we have an opportunity, if we continue the momentum we have, to push our way to the table in a lot of different conversations, whether it is about diabetes management or, you know, cancer molecular diagnostics. We need to be at those tables, not just have folks assume that the test is being done right somewhere and they can pick which test it is. You know, we're really the testing experts. So I think that's one of the great things that has come out of that, but I think we have to play on it.
So,
I agree.
Thank you. Karen, go ahead, Karen.
Yeah, I was gonna say, I completely agree with Dr. Prokop. And, you know, I think our impact has really been fairly broad. I mean, we all are focused perhaps on PCR testing here, but when I look at, you know, our team handling coagulation abnormalities, the phenomenal work our blood bank has done. You know, we stood up a strong convalescent plasma program at our institution. And so I think there's many examples of where the lab has really made an enormous difference in patient care, in outcomes, as well as hospital finances. We need to continue to remind them of that at every opportunity.
So you're both pathologists, you're both practitioners around standard of care. You're both clearly flying by the seat of your pants as you're developing SOPs and trying to figure out what's the best way to approach this and scale up these tests, right? But would either one of you be willing to share any negative changes or any bad habits that you think that the laboratory community has gotten into out of necessity that we must eliminate as soon as possible once this pandemic has been controlled?
You first, Dr. Call.
Well, I wouldn't say it's a bad habit, but I have found myself, and the entire lab has found themselves, and it's a nationwide phenomenon, making decisions on less data than we've ever had before. You know, we're being faced with committing to large volumes of reagents when we don't really know the test performance, nor do we know if we'll be able to get those reagents. And so we're, you know, I think we've done a lot of things right. We've also done a lot of cross training and you know, really wonderful things within our labs that we need to continue. But, you know, seat of our pants is a good way to describe it, because I don't think it is as data driven, as cautious as perhaps we generally operate. And that's been frustrating.
Yeah, you know, and I don't think what I'm going to say is something that we've done wrong. I think it's something that has occurred is, you know, I think we are really burning out our medical laboratory scientists. There's not enough to go around. There's, you know, folks that are actually being denied PTO because we have to run these tests. And so, you know, I think that, you know, looking at that workforce, I know ASCP has done a lot of work around workforce, around reimbursement, around burnout, et cetera. I think that's really important, because I think there is an unfortunate, you know, burnout of frontline workers that sometimes goes overlooked.
So,
You know, I agree. And one more comment is, I think this could be a real core of a campaign to attract, you know, the best and the brightest into medical technology, medical laboratory science, and pathology. I think this is a great opportunity, and you're taking advantage of that already at ASCP.
So let's go to our medical laboratory science expert, shall we? And let's ask Mrs. Chatram to weigh in on something. Jasmine, in your interactions with the laboratory community, you've been very extensively involved headlining CDC outreach programs like Project ECHO. What are your biggest takeaways from some of those experiences regarding COVID-19, and what were you surprised to learn?
So thank you. The Project ECHO is actually not being used for outreach for COVID-19 right now. It's primarily focused on academic medical centers and consolidated hospital systems sharing their diagnostic practices with smaller community hospitals. What we have been using is the clinical laboratory response COVID-19 calls, and these happen every other week. And it's a really good opportunity to share information from CDC. What we've been doing is doing surveys throughout the calls. We've been taking questions. We've been using that information to guide our agenda and the topics that we focus on. I think that it's been, you know, successful in that we've had over 2,000 participants at one time on the call. We have facilities from all 50 states. We have healthcare, commercial, independent laboratories participating in these calls. We get lots of great participation. We've had great speakers, some from the laboratory community as well, not just from the federal government. And as far as what we've learned during this outreach, you know, I've been doing preparedness for years. It's one of my titles at CDC, Associate Director for Laboratory Preparedness, and we've been working specifically in the last few years. I've been working with the clinical laboratories on preparedness issues, and you know, for me, what's happened is what is expected to happen. I think the response from the laboratory community has been great. They've always been willing to be partner with the federal government and with public health, and they're doing that now. We see the labs doing everything they can in spite of some of the challenges that they're experiencing. And they're willing to share those experiences and expertise with each other. And so from where I sit, it's what I expected to happen.
So let's stick with that for a minute. During these in these calls and during these information sharing sessions, have you particularly seen innovative actions or technologies that have seen and been, shared with individual labs that have been adopted, such as, for instance, testing demanding or conserving testing resources, or adopting better meeting testing demands, et cetera, turnaround times? Have you seen innovative actions that have been taken, being shared, that have allowed other laboratories to scale up and be more effective?
Yeah, we've had some guest speakers, like I said, non-federal guest speakers from clinical laboratories, commercial laboratories, even academia. And some of the things that I've heard in those presentations, as well as through comments to our through the call, Zoom, chat box, whatever you want to call it, as well as to emails to the CDC. We're hearing things like laboratories are using multiple platforms to diversify what they have available to them so that they're not relying on one test and one manufacturer for reagents. We're hearing things about pooling specimens, that's grouping specimens for testing, 3D printing of swabs so that they can deal with the shortage of swabs, making viral transport media in-house. And we've even heard of things like testing other specimen types like saliva, validating those sample types so that relying on swabs, since that's the preferred sample type right now, and most of the assays, PCR assays, are on nasopharyngeal and nasal swabs. Bringing another sample into the mix helps with also addressing that issue with the shortage on swabs. So those labs that we're hearing are validating those assays and submitting them to FDA for emergency use authorization. And we're always willing to hear more from the laboratories, so they're welcome to reach out to CDC through any mechanism, any of our email addresses, and provide information, and we can share that with the community too.
Dr. Prokop, I think you were one of those speakers earlier last month, I believe it was. Let me ask you, in reference to what Jasmine is discussing, best practice sharing is important. I'd also be very interested on what you think. Well, first of all, what science is missing? Okay, what research should we be looking at, or what, if you had your druthers, what research would you be funding today to ameliorate additional effects or prevent this from occurring in the future?
Well, first of all, I want to thank Jasmine and her group for having me as a speaker. It was a great forum to participate in. And so, I think some of the questions we're asking right now is, COVID-19 has a long tail of convalescents, and we are seeing folks that have recovered and are still PCR positive. And we know that those folks are most likely not infectious from some good South Korean studies, from inability to culture the virus, et cetera. However, they're still PCR positive. So it would be nice to have a test that differentiated infectious from previously infected. There's also going to be a whole human immune response to COVID-19. And there's going to be, there's important information we need to know about acute responses. We're seeing papers on myocarditis, other cardiac issues associated with this, renal disease. This is probably different in different patient populations. So what are genetic determinants of different types of disease, different severities of disease you can get with COVID-19? So there's still a large number of unanswered questions. So I think as the science moves from direct detection, those are some of the things we'd like to study next.
Dr. Call, thoughts?
Yeah, I'll add a couple comments. And first, I do want to thank the CDC and Jasmine for the calls they've organized. I'm on those as often as a listener and have learned a great deal. So, that's one of the ways that I think we need to figure out how to better share information. I think a big part of what we can do is communicate. And the CDC calls, a couple of the national listservs that our professional organizations sponsor have just been a lifeline, I think, for all of us as we go through this. I think another positive has been the fact that some of the online journals are getting quality manuscripts published and available to all of us much more rapidly than I've ever seen in my career. And again, disseminating this so we can all learn from what other laboratories are doing, I think is really key. And as Gary said earlier, I think we do need to learn from this entire experience because no doubt it will happen again. With respect to the science around COVID, there's tremendous amount we don't know. We need biomarkers. We need to know about the different variations in the genome of the virus, and there's just so much going on right now. I think all we can do is fill our biorepositories and our data repositories with information so that when we have time, when this settles down a little bit, we can go back and look at the combination of biosamples, data, and outcomes, and again, try to put more pieces of the puzzle together so we do have tools for this or other outbreaks in the future.
There was last week we had a great conversation at the town hall related to healthcare disparities and issues for which some patients are at a more severe risk for this particular disease. And I'd like to stick with that conversation for a minute, Dr. Call, because our nation is embroiled in issues of disparities to some degree. We're actually fueled by the pandemic, correct? I mean, they were there before, but now the pandemic has fueled it. Do you think healthcare for underrepresented minorities will ultimately benefit from the pandemic, or is it making the situation worse?
It's probably making it worse right now, and I have hopes that it will benefit because I think this is a time when we're all, really looking at how we operate within our institutions, but also across our systems and what we can do better. We had a conversation yesterday within our institution, just looking at how can we share our capacity for testing with other institutions. And I'm proud to say that we have helped others in the Chicago area. Similarly, we've shared convalescent plasma, but many of the less socioeconomically blessed institutions will have a hard time putting together either testing or treatment. And I think, we need to really pay attention to that and make sure that these resources are fairly used.
I'm not sure if anybody else would like to comment on this, particularly Jasmine, maybe from the federal level. There's opportunities here. What are your thoughts?
I think this is an important issue and CDC is looking at it, and I'm not involved in that particular task force that's focused on that, but I will say that this is related to some of the reporting requirements that were recently asked laboratories to provide to public health and ultimately to CDC. This is related to guidance that went out from HHS, related also to the CARES Act, which requires laboratories to report data to public health. And there are some data elements in there about race and ethnicity. And we realize that there's a burden for the laboratories to collect this data, but it is important for us to be able to understand the impacts to different ethnicities and races.
Jasmine, let me ask you about U.S. spending. You think the United States is spending its public health dollars effectively and efficiently? Do you think there's a need to reallocate resources? What do you see going forward and what might help us bring a solution to this condition?
So that's a tough question for me to answer. There is a lot of funding coming to CDC and it's being allocated for lots of different things. I can only talk about the funding that I've used and how it's being used, but I would prefer to defer that question.
Dr. Call, what do you think?
I would agree. I think it's going to take a concerted national effort to, change how this is done. And that is going to be a slow process and hopefully one that is not embroiled in politics, but it is upon us to do it. Okay,
so you and Dr. Prokop have both been working with the federal government, with the American Medical Association, even working to ensure that the right patients are being tested at the right time and that scarce supplies are distributed to states in a reasonable and rational fashion. Now, given the nation's supply chain issues, what should the federal government be doing to ensure that we are prioritizing testing to the right patients at the right time? Gary, let's start with you.
Yeah, I'll tell you, Blair, one of the things that we've learned, and, Dr. Call and I have been on some of the same calls, is there is a lot going on behind the scenes. And I think we were both shocked on finding out some of the great initiatives that were being done. We just didn't know they were being done. And they hadn't trickled down to our laboratories yet. So, first of all, I'd like to, kind of give a shout out to the folks that really are doing all that work behind the scenes. And, And this is work to help companies gear up production of everything from reagents to swabs, et cetera. You know, I think it's similar to the question that you asked Jasmine, you know, is the government spending enough money? What is the government doing right now? I think both of these have a same common denominator, is that we're being reactive rather than proactive. You know, we're throwing a bunch of money at CDC right now because of this pandemic. We should have thrown all this money at them, you know, 7 years ago in pandemic preparedness. And so same story here with regards to supply chain issues. And again, this is where this no blame morbidity mortality conference after COVID-19 is over needs to go. How can we secure a adequate supply of swabs for this country going forward if this were ever happening again? How can we assure, and then you can fill in the blanks for every diagnostic and therapeutic and ventilators that we might need, but we need to be proactive rather than reactive.
Well, first of all, Dr. Prokop, by the way, congratulations. I understand that you were recently invited to advise the National Testing Forum that's been organized by Admiral Kuyar at Health and Human Services, and ASCP is proud to have nominated you for that position. So thank you for sharing your expertise with the federal government. And as you mentioned, obviously, you probably can't go into all the details in terms of the operating procedures, et cetera, with regard to that forum, but prioritizing scarce resources is probably the biggest part of that formula. Am I wrong, or
No, you're right. And I will say they are, you know, really targeting the most vulnerable populations. So, you know, like I said, I think great things are going on behind the scenes. We don't always hear about them. And again, they're not trickling down to, you know, our you know, everyday laboratories. So I'm not saying we can't do better. We can do better. I think good folks are doing as good as they can with the tools they have. You know, it really is in the middle of a firestorm. So, you know, I think we need to get through this, you know, learn our lessons and do better the next time. But yeah, no, I'm glad to have, you know, gotten a glimpse behind the curtain. And, you know, I think, you know, Dr. Call also did on some of the AMA calls. And again, things aren't perfect for sure, but I think people are working in the right direction.
So you're an optimist?
I am still.
Good. Dr. Call, are you an optimist?
Yes, I've got to be an optimist. I think we all do, but again, we have a lot to learn. And I think we all know this is going to happen again sooner or later, some number of years down the road. We need to be ready, and we need to start thinking about that now. And whether it's funding for the CDC, funding for the WHO, because I do think it's going to take a global preparedness and a global level of communication so that we can avoid what we're doing right now. I think better coordination between hospital labs who have a key position taking care of patients right there in their hospital with the public health labs and the big reference labs. I think they all have a place to play, but we need to have a better exchange and coordination between those, you know, providers of laboratory services. There's many opportunities here. I think that we can get it right, but we need to start thinking about it sooner rather than later.
And does anybody, any of the panelists, feel free to weigh in on this, but the shortage of testing supplies, I mean, clearly we know that it's has reached proportions that we had not predicted, but are those shortages, have they gotten any better than they were, say, a month ago or even 2 months ago? What's your opinion on that and what you see in your practice? Dr. Prokop?
I might want to say a little bit better than, you know, kind of, you know, as I mentioned, the you know, kind of chaos we experienced at the very beginning. So there's a little bit of a rhythm to it now. Not as many orders will go unfilled and you know, send us scurrying, but it's still, you know, nowhere near where we want it to be. Dr. Call, how about in your lab?
You know, we've had a couple of near misses with running out of supplies and reagents that still are keeping us up at night. You know, this past week or so, it's been a little bit better, but, you know, it amazes me that we've had to adjust testing for papillomavirus and chlamydia and you know, hepatitis and HIV, because these assays are run on some of the same instruments. And so we are really having shortages that affect, you know, a broad delivery of medical and laboratory care. And that's been very frustrating.
Well, maybe we could take the lessons we've learned and maybe implement a few appropriate utilization methodologies as well, so we can help clinicians understand appropriate testing too. Because we certainly are in a dilemma right now, how to triage patients for care in the age of short supplies. Obviously, the short supplies are likely to be exacerbated this fall. Wouldn't you agree, any of you? Because of the fact that we're going to be facing yet another wave of potential influenza and others. But what are your thoughts in terms of measures, maybe Jasmine, that we could take, or best practices you've learned through the CDC's work, so that we can be better prepared for the fall?
This is Jasmine. I'll chime in on this one. First, I wanted to go back to the reagent shortages issue and just comment on that. CDC has been providing reagents to the public health laboratories. That's been our focus. We do that through a program called the International Reagent Resource. And the Department of Health and Human Services, HHS, has been focused on getting materials out to the clinical laboratories. On our last clinical laboratory COVID-19 response call, we had someone from HHS who's leading the team, the testing and diagnostics work group. And this call happened just this past Monday, so 2 days ago. And the transcript is available for anybody who wants to go back and listen to it. But HHS mentioned on that call that they have secured 18 million swabs and viral transport media, and they'll be distributing that. Now, it is being distributed based on state testing plans that have been submitted to the US government in response to the CARES Act, which I already mentioned. Also, the government has been having conversations with manufacturers to understand what's available in their inventory. And they are encouraging laboratories to try to diversify their platforms so that they're not relying on one manufacturer, as I mentioned before. We are using some of the data. I also mentioned the need to send data to public health. And so this data is being used for lots of different reasons. It's also being used to help us understand where there are spikes in testing, and so where there might be surges in cases, and where supplies might need to be directed. The other thing that I wanted to comment on, you had a second part of that question. Oh, the fall, what's happening in the fall. So the other thing that CDC is doing is that CDC has developed a multiplex assay for SARS coronavirus 2, and it also has markers for flu A and flu B. And so this multiplex assay has been distributed to public health laboratories, but what CDC has done is publish the primers and probe sequences. And we've also worked out with FDA to allow a right of reference. So we're encouraging labs and manufacturers to use this information to also develop tests and submit them to FDA for authorization. And we're hoping that this would allow a greater production of multiplex assays out there, which would allow for testing for flu and SARS-CoV at the same time, which would reduce the amount of reagents needed, which would identify co-infections quickly. So this is all in an effort to try to help address the problem that we are potentially going to see in the fall. The other thing CDC has done is encouraged FDA to prioritize any of these assays that come forward for authorization for multiplex testing.
Fantastic. I think we're going to switch over to the audience and get some Q&A from the audience, and I'm going to ask again, any of you who would like to answer this, just feel free to raise your hand and I'll call on you. But let's go straight into that, and then we will work back into a couple other questions. I still want to talk a little bit about pooled specimens. I want to talk a little bit about some innovative technologies that are out there and opportunities for us to put at least some guardrails around opportunities moving forward for testing. But let's start with a question that is from Bruce Davis. And Bruce is asking, is there anyone doing proper assay comparison studies so that only quality tests are used in decision-making going forward? Anyone? I think everyone is, aren't they? But I mean, I assume that you're doing some of that. Dr. Paul, you want to share any of your?
So we are, and this is something that normally, before we launch an assay, we would have a great deal of data, and so we'd know what the performance of the assays would be. And that just hasn't been possible this past few months. So I think that is happening. Dr. Prokop has published in this area. A number of labs are now getting to it, but it's difficult to do this sort of work in the middle of the storm. And, we're trying to preserve our reagents and our techs who are working so hard. It's just a difficult time to be doing some of these sorts of things. But as time goes on, there have been a number of reports starting to compare head-to-head how assays are performing, and that does help us a great deal.
Dr.
Gary, you may
Prokop,
have some more comments.
yeah, Dr. Prokop, share your perspective and your experiences.
Yeah, no, hopefully I've got a few minor edits to address, but hopefully our paper, our 5-test comparison will be coming out in American Journal of Clinical Pathology. But yeah, we've done it, other folks have done it. As Dr. Call mentioned, it's been very helpful to have some of these preprints come out early. It starts to direct you on things to look out for, et cetera. And so, I think this is a time where we've really seen the, laboratory community come together and share. And, Karen and I may pick up the phone and say, hey, have you experienced this? And, we all have colleagues. And so, we've really banded together. So I think there are those the assays in the literature already. There'll be more coming, forthcoming. As Dr. Call mentioned, we are, I got asked to give grand rounds down at University of Miami, and my title was COVID-19 testing, pipetting in a firestorm, and so it's tough to do these comparisons when it really is all hands on deck. But some good ones have been done, and I think more will be forthcoming.
Well, thank you. Looking forward to reading that. The next question comes from Dr. Nathan Johnson, and he's actually asking a pragmatic question. And that is a laboratory reimbursement for COVID-19 you believe sustainable for the long-term sustainability?
Well, we certainly hope so. And I think that was one of the positive things that happened early on. A reimbursement rate was set. It wasn't really adequate. And I think the laboratory community spoke out. The government listened. Dr. Brooks was on a call with many of us back several months ago, and reimbursement increased. Whether that's sustainable from the payer side, I don't know. I think at this point, payers are not paying for a lot of health care that they normally would. So hopefully the money all comes out in the wash. But it certainly has allowed labs to offer this testing without some of our usual concerns about reimbursement.
Okay. Go ahead, Dr. Pro.
No, I was just going to say, and I think the reimbursement question will also be linked to appropriate utilization. We just got great guidance from CDC about this long tail of convalescence that, once you're positive, you don't need to be tested for another 90 days. So I would not blame a payer for denying those unless there was a good medical reason. And there are some good medical reasons, immunocompromised hosts who may not be clearing virus, et cetera. But we're having a lot of repeat testing that, may not be necessary. And then on the front end, who actually needs to be testing? This goes back, kind of Blair and ASCP team to this need for national testing guidelines. Why did we waste so much money and time on serology at the beginning of this? I mean, these kinds of crazy things.
Well, that's true, because we know about the misuses of serology with HCV. We know about it with other diseases, rubella, measles, you name it. I mean, and now we're facing the same firestorm in terms of sensitivity. But I think we have to continue to educate our clinical colleagues. The next question comes from from Becky Little, and Becky Little is asking, does anyone know much more about the saliva testing, the collection process for saliva testing, or even the sensitivity and specificity? Anything you want to share? Any of you are utilizing those specimens in your laboratory?
Gary, are you? We're starting to play with it. I'll let you go first.
Yeah, so we've done a study, also submitted, not yet accepted, but, we're of course very interested because of the Yale work, right? Mm-hmm. And so, and now a newer assay released by Yale. And so we looked at saliva versus nasopharyngeal swabs in symptomatic outpatients and found it qualitatively equivocal. So positives were positive, negatives were negative. Unlike the Yale study, the viral loads were lower in saliva in our study versus nasopharyngeal swabs. So, you would worry if you ever were, branching out into asymptomatics who may have a lower viral load that you could miss them. But anyway, that was our experience.
Okay, the next question is for you, Jasmine, and it's a little bit of a concern that you've heard a lot about, and that is that there's been some complaining in the national press, et cetera, about the long turnaround times, right? I think there's some demystifying around this conversation as well about these long turnaround times, but they're interested, this is a question that's for anybody, but it's specifically requested to you. You know, laboratories that are complaining about this due to shortage of supplies and reagents, et cetera, is CDC really amplifying its efforts to deal with this TAT, turnaround time issue?
And I guess when you say amplifying its efforts, meaning are we doing something to address the supplies and the reagent shortages issue?
Right, correct.
So, right, and so I kind of already addressed it in saying that, you know, CDC is not directly responsible for supplying reagents and supplies or managing that right now. It's an DHHS function, Department of Health and Human Services, and they are, you know, trying to work through this issue with at least the swabs and the viral transport media, and then having these conversations with manufacturers, instrument manufacturers, both for making instruments as well as manufacturers for tests. So, you know, the reagents and understanding where the inventories are and helping to provide information and coordination around where the needs are.
Okay, great. The next question we have is from a resident, okay, a fourth-year resident. So obviously your residents are embroiled in this, particularly this is Gerald Lilly, who's a fourth-year medical, I'm sorry, he's not a resident, he's a medical student, which we need to recruit into residency, all right? So here's the recruitment pitch that I'm going to ask both you, Dr. Prokop and Dr. Call, to give Gerald Lilly, a fourth-year medical student, all right? Wants to know, do you think there will be opportunities in innovative clinical pathology training or projects related to COVID-19 during residency?
After you, Dr. Call.
Well, I'd say there absolutely are. And our residents were involved in this throughout. You know, it was interesting to watch the effect of this last 2 months on residency training, because there was a tremendous increase in the amount of virtual training that we were giving. I think that was probably a good thing. But we also, you know, use these opportunities for our residents to become involved in quality and data-driven projects. You know, really see front and center, you know, these things happen. You have crises in the lab and you have to, you know, develop a plan and respond to it. And it's interesting, fascinating, frustrating, and everything rolled into one. But I think this is an excellent learning opportunity for anyone in training.
Three of the residents from our group will be on the paper I described. So, you know, absolutely, they're engaged throughout.
All right, fantastic. This next question is from Timothy Cagnoni, and he's asking, with the new guidelines to not test again for 90 days, as you referenced earlier, Dr. Prokop, for positive patients, we see nursing homes requesting 2 negative tests before they can accept a previously positive who is asymptomatic. Is there any work in progress to help nursing homes understand that viral shedding is not infectiousness, and because this is spending unnecessarily resources, as you mentioned, and often done every 24 hours?
Yeah.
You know, this really goes back to everyone making their own rules, right? So it's tough when everyone's making their own rules. And so you know, this is where, you know, national guidance, and I give CDC a lot of credit for doing this, but then what happens when nursing homes, hospitals, et cetera, don't follow that guidance? Well, you know, I mean, is there a stick that can go along with that perhaps they lose some of their federal funding? You know, so you need to follow CDC guidance or else, et cetera. So, you know, nothing we're going to solve here, but you can see it's a challenge when, you know, 50 well-meaning governors are trying to figure this out themselves. So, you know, great guidance. We just need more of it and need to standardize.
Yeah, I
Okay.
completely agree. And I think, you not only the nursing homes, some of the other hospitals in the area, but also, looking around the Chicagoland area, what's going on with our back to colleges, those that are going back. There are some that are requiring one test before a student reports to campus, others that are planning to test every week. Tremendous variability in terms of the plans being suggested. So I think some sort of a well-publicized national guidance would be very, very helpful.
All right, Dr. Prokop, we're going to be leaning on you for that guidance. And again, thank you. Before we get into the tail end of this particular town hall event, I want to kind of step out on a ledge a little bit. And actually told our panelists earlier that we might do a couple of surprises tonight. And I'm going to start with Dr. Call, because I know she's prepared for this. Okay.
Oh,
We love
lovely.
surprises.
Okay, so Dr. Call, you are asked to choose between one of the following: a rapid point of care test, an 80% effective vaccine, or a 99% effective therapy. Which one and why?
And I can't have all three?
Nope, you get one of the three.
I think I would have to say a 99% effective therapy. Off the cuff, because I don't know that I trust us to behave ourselves. We haven't seen a very good track record in the American public in terms of doing the things that they're supposed to do. So, we might test them and people may still go out and do things. They may not get tested. So as much as I would like to, give the test as my answer, I don't know that that's going to do it. So I think I'm going to end up choosing the therapy.
I'm going to ask the same question, although I wasn't planning to Jasmine. Jasmine, which would you choose? Which of the three?
I'm also going with the 99% therapy.
Okay.
Having the results of an antigen test is great. And this is personal opinion. I'm not speaking on behalf of CDC right now. I think that, knowing whether or not I'm positive is helpful because then I can self-isolate. I don't know if I will be able to get the vaccine. I don't know if it'll be available to me, but having a therapy that works, that sounds great.
All right. You ready, Dr. Prokop?
I am ready. I'm bracing myself.
Okay. You look prepared in that chair. So let's get started, shall we? It's 2025, and we've solved COVID-19. Now reports are emerging of a new respiratory virus in Thailand. What should the immediate response of the U.S. be by the federal government and by laboratory networks?
So we will have learned the lesson. This is the perfect world, right? We will have learned the lesson. So we will have a rotating stockpile of whatever we need. And if it's something that may, rust like a ventilator, we have plans in place to build them quickly. CDC, WHO are all over this. I give Jasmine and the CDC team a lot of credit for this publishing of primer and probe sets. That hasn't been done in the past. So this is a demonstration of progress. And so laboratories, Karen's laboratory, mine, all the reference laboratories have ample opportunity to gear up before this is on our shores.
Well, Jasmine, since you were referenced, would you like to add to that comment as well?
No, I think Dr. Prokop covered it very well.
Okay, he has a future as an advisor with the CDC as well. Okay, put on another hat, Dr. Prokop.
Blair, I'll add a comment or two if I may.
Please.
I think to that scenario, which I wholeheartedly hope for, we'll have a well-funded CDC and representation at the WHO so that we can get samples, again, share protocols, share reagents, share reference materials, so laboratories will have an easier time bringing assays up into their laboratories, and we'll have some idea what the performance standards should be to have an adequate assay. And I think we'll also have a system where, hospitals are dealing with the patients that present on their front door, maybe the less sick outpatients or those who are going to be going to the reference labs. The enormous numbers of samples that go to the public health labs can be shared with the hospital labs. It'll just be more integrated and more functional, I hope, as well.
Okay. All right. The last question is going to go to you, Jasmine, and that is, what can we at ASCP and other laboratory organizations, all of our sister organizations, what can we all do to further the vital mission of the CDC that Dr. Prokop's been referencing, that Dr. Call's been referencing, that we want to make sure that we have a solidarity, a system that supports, but can you give us some advice how we can continue support, and look forward to continuing to support the CDC in their incredible Herculean efforts?
Well, I want to thank ASCP again for having me on this town hall, and I want to thank them for their partnership. The ability to do outreach to the clinical laboratories, the number of laboratories that are out there, we could not do that without the help of our clinical professional organizations, including ASCP. And the clinical laboratory response calls that we've been having and hosting every other week, again, could not have done that without the promotion that's been done through ASCP. I think that, and as well as other clinical laboratory professional organizations that are partners with CDC. I do think that going forward, it would be helpful to continue to help us to do that outreach, to promote the messages and information that CDC has to share with the clinical lab community, because like I said, we can't do it by ourselves. We can't reach all these laboratories. We have gotten a lot of feedback from ASCP and other lab organizations about the gaps and the needs of this community, and we continue to need that information. It helps us to focus our efforts, helps us to develop important guidance. And so, you know, there's plenty that ASCP can do, but from where I sit in the role that I play in this response, which is to have this outreach to the clinical laboratory community. I would just ask that ASCP continue to do what they're doing and provide that communication and coordination and information sharing with CDC. And again, thank you for all that you're doing.
Well, we thank you because this has been a lesson that we've learned, baptism by fire, so to speak, hasn't it? And unfortunately, we didn't ask for it, but we have had to deal with it, and it has been because the CDC has truly been out there as a leader and supported helping moving forward this moving targets on this particular disease. Dr. Call, any further words of wisdom for us?
No, other than I do remain an optimist, and you know, I appreciate the information sharing in the town halls and you know, the programs that ASCP's put together. I think it's really helped us all.
Okay, and Dr. Prokop, final word.
No, I echo those. These ladies have summed it up perfectly. So thank you.
All right. So first of all, we're going to share some information with you, and we'd like just to begin by thanking everyone for attending tonight's town hall. Particularly thank Ms. Chatram, Dr. Call, and Dr. Prokop. Again, just tremendous luminaries, and bless you for being part of the solution, for providing expertise and helping all of us govern the right decisions as we migrate through this pandemic. Before we sign off, we have some exciting news to share with you. But before we do, we're going to remind you guys that the town halls have been recorded. You can view it, or you can share it with your colleagues at ascp.org/townhall. It's also subtitled as well for this event, so it's available on the site and will be available very soon. The town hall is also available for CME and CLME credit. You can claim that credit by going to the same site at ascp.org/townhall. We also are very, very excited to share with you and invite you to the ASCP 2020 virtual annual meeting. That's going to be held September 9th through 11th. And tonight we're announcing two dynamic opening keynote speakers. The first is Rita Wilson. The second is Chris Como. Now, Rita Wilson, if you've been following her and her husband, Tom Hanks, Miss Wilson is not only just a talented actress and singer, but she's more importantly is been through the early journey of COVID, has been a convalescent plasma donor along with Tom Hanks, and she's going to be sharing her story with us and focusing on how, as a champion of the laboratory, we can be proud of the work that we have done. In addition to Ms. Wilson, we're going to have another patient champion, and that's Chris Como. And if you haven't seen him, he's been an anchor on CNN's Como Prime Live. Criminal Prime Time, that is. Both he and Ms. Wilson are really going to be focusing on that laboratory's role in testing, diagnosis, the treatment of COVID. And we're thrilled that they're going to be joining us for the ASCP 2020 virtual. So please look forward to sharing the stories. They're going to be talking about you and how you are the practitioners that are the laboratory that saves their lives. And more importantly, we're going to ask and encourage each of you to submit your personal questions for both Ms. Wilson and Mr. Como through the town hall email address. And so between now and then, which is about 3 weeks away, if you just go on townhall@ascp.org, email us, ask your question, and please provide your name. So when we ask these individuals, we can discuss who you are and we can share your question with them. I'd like to remind everyone that this ASCP 2020 virtual event is free for members. And for non-members, you can attend for a nominal fee, that is. You actually will even receive ASCP membership for the remainder of the year. So you'll find out more if you go to ascp.org/2020. And lastly, another piece of exciting news. We invite you to join us for our next town hall. At the next town hall, which will be taking place on September 23rd at 2 p.m. Eastern, where we'll be joined by a very special guest, Dr. Anthony Fauci of the U.S. Coronavirus Task Force and the Director of the National Institutes of Allergy and Infectious Disease. And this will be presented as a one-on-one fireside chat with Dr. Fauci. September is going to be a big month for ASCP, and we look forward to sharing it with you. In the meantime, please have a great evening, and please stay safe. Good night, everyone.